General Cardiac Assessment 1. Chest pain that is not relieved by rest or nitroglycerin. That is never normal. Always suspect myocardial infarction. Your role is to put the patient on oxygen, obtain an ECG immediately, and notify the provider. NCLEX-Pearl. Unrelieved chest pain is an emergency until proven otherwise. 2. Crushing substernal pain that radiates to the left arm or jaw. This is the classic presentation of an MI. Give aspirin as ordered and prepare for MONA, morphine, oxygen, nitroglycerin, aspirin. Safety concern. Every minute the heart muscle is deprived of oxygen, more tissue dies. 3. A new S3 heart sound. This is not an innocent finding in adults. A new S3 can be an early sign of heart failure. Your action is to assess for pulmonary congestion and notify the provider before it progresses. 4. Jugular vein distension, peripheral edema, and lung crackles. These are the hallmarks of right-sided heart failure. Position the patient upright, monitor fluid balance, and prepare for diuretic adjustments. The safety pearl. Fluid overload worsens quickly if not caught early. 5. Frothy pink sputum. That is pulmonary edema. The priority here is the airway. Sit the patient up in high Fowlers, give oxygen, and prepare for IV diuretics. This is a life-threatening emergency. 6. A weight gain of more than 2 pounds in a single day or more than 5 pounds in a week. This indicates fluid retention. Daily weights are your most accurate way to track fluid balance in heart failure patients. Don't rely solely on edema. 7. A mean arterial pressure less than 60. This means the organs are not being perfused adequately. It's a dangerous situation and requires immediate provider notification. The NCLEX-Pearl tissue perfusion depends on MAP. 8. Cool, clammy skin with a weak, thready pulse. These are classic signs of shock. You must act fast. Apply oxygen and start IV fluids unless contraindicated. The risk is circulatory collapse. 9. Sudden severe back pain in a patient with uncontrolled hypertension. That's an aortic dissection until proven otherwise. Keep the patient calm, lower the blood pressure with IV medications, and prepare them for surgery. NCLEX nugget. Never ignore tearing or ripping back pain with hypertension. 10. Syncope during exertion. This suggests severe aortic stenosis. Place the patient on fall precautions and notify cardiology. This condition carries a high sudden death risk. Rhythm and conduction. 11. A heart rate less than 40 beats per minute with symptoms like dizziness or hypotension. That's symptomatic bradycardia. Apply oxygen and prepare to administer atropine. Remember, symptomatic bradycardia requires intervention. 12. Sustained ventricular tachycardia. First, check for a pulse. If pulseless, begin CPR and defibrillate. If there is a pulse, administer antiarrhythmics. Safety pearl, VT can turn deadly in seconds. 13. A new onset of atrial fibrillation. This carries a high risk of stroke because of clot formation. Place the patient on telemetry and anticipate anticoagulation therapy. 14. An irregular rhythm with no P waves. That's atrial fibrillation. Assess perfusion and notify the provider. Don't confuse it with other irregular rhythms. This one carries the highest embolic risk. 15. A prolonged QT interval. This predisposes the patient to torsades de pointes. Place the patient on continuous telemetry and avoid medications that can lengthen the QT further. 16. ST elevation in 2 or more leads. That's a STEMI, a true emergency. Activate the cath lab and prepare for PCI. NCLEX-Pearl. STEMI equals immediate reperfusion. 17. ST depression or T-wave inversion. These changes mean ischemia. Monitor closely, give oxygen and nitroglycerin, and escalate if symptoms persist. 18. Complete heart block. This is life-threatening because the ventricles and atria aren't communicating. Prepare for pacing immediately. 19. Frequent PVCs in a patient who just had an MI. This can be a warning sign that ventricular tachycardia is coming. Notify the provider and monitor closely. 20. Ventricular fibrillation. This is cardiac arrest. Start CPR right away and defibrillate. Survival depends on seconds, not minutes. Post-op cardiac procedures. 21. After a cardiac catheterization, active bleeding or a growing hematoma at the site. This is an emergency. Apply firm pressure and notify the provider. 22. Absent pedal pulses after a femoral catheterization. That means limb ischemia. Time is tissue, so call immediately. 23. New onset of back pain after a femoral cath. This can mean a retroperitoneal bleed. Check vital signs and notify the provider right away. 24. Chest pain after a PCI. Think re-occlusion. Get an ECG and notify cardiology. 25. After CABG surgery, chest tube drainage that suddenly exceeds 150 milliliters per hour. That's a hemorrhage until proven otherwise. Call the surgeon immediately. 26. A CABG patient with muffled heart sounds, jugular distension, and hypotension. That's Beck's triad for tamponade. Prepare for pericardiocentesis. 27. Sternotomy wound dehiscence. Cover the wound with a sterile saline dressing and notify the surgeon. Never attempt to push the wound closed yourself. 28. Redness, drainage, or fever at the incision site. These are signs of infection. Report promptly before it spreads. 29. Hiccups after pacemaker placement. That suggests the lead may have migrated and is irritating the diaphragm. Place the patient on telemetry and notify. 30. Pacemaker failure to capture. Always check the leads and prepare for further intervention. Failure to capture means the pacemaker is firing but not producing a heartbeat. Heart failure. 31. Dyspnea at rest. That's a big warning sign that heart failure is worsening. Put the patient upright in high Fowlers, start oxygen, and notify the provider. NCLEX nugget. Dyspnea at rest is never stable. It means decompensation. 32. Crackles that don't go away with diuretics. This isn't just fluid overload anymore. This is pulmonary edema. Escalate care right away. Untreated pulmonary edema can drown the patient from the inside. 33. Needing 3 or more pillows just to breathe at night. That's orthopnea, a red flag for decompensated heart failure. Adjust positioning, monitor closely, and call the provider. 34. A BNP greater than 100. That confirms heart failure is present. Combine BNP results with daily weights and fluid monitoring for the best picture. 35. Fatigue, edema, and poor appetite. Those are classic right-sided heart failure symptoms. The nurse's job is to monitor daily weights, manage sodium intake, and watch for worsening fluid retention. 36. Acute weight gain in a patient with heart failure. Always assume fluid overload. Check for edema, listen to lung sounds, and anticipate diuretic adjustments. 37. Low potassium after diuretics. Hypokalemia is dangerous because it triggers arrhythmias. Always monitor ECGs and replace potassium as needed. 38. Digoxin toxicity. Watch for nausea, blurred vision with halos, and bradycardia. If you see these signs, hold the drug and check the digoxin level. NCLEX nugget. Toxicity shows up first in vision and heart rate. 39. Severe hypotension after starting an ACE inhibitor. This is the first dose effect. Patients can bottom out quickly, so monitor blood pressure closely after the first dose. 40. A dry, persistent cough from ACE inhibitors. This is a common side effect, not an allergy, but it can be intolerable. Notify the provider. They may need to switch to an ARB. Valvular and structural disorders. 41. A new heart murmur with fever. Always suspect infective endocarditis. Get blood cultures before antibiotics. Safety pearl. Treatment must be started quickly to protect the valves. 42. Splinter hemorrhages under the fingernails. These are subtle but important signs of endocarditis. Don't overlook them on exam questions. 43. Sudden chest pain and fainting in a young athlete. Think hypertrophic cardiomyopathy. Place the patient on telemetry and restrict exertion. This condition can lead to sudden cardiac death. 44. Chest pain that improves when the patient leans forward. That's pericarditis. Treat with NSAIDs and monitor for worsening. The key pearl, position matters here. 45. Pericarditis that progresses to muffled heart sounds, jugular distension, and hypotension. That's cardiac tamponade, a life-threatening complication. Call for help and prepare for pericardiocentesis. 46. Rheumatic fever after a strep infection with a new murmur. This should raise concern for endocarditis. Always ask about recent sore throats on exams. 47. Aortic stenosis causing syncope, angina, and shortness of breath. This triad signals high risk. Notify cardiology right away. The patient needs intervention. 48. Mitral regurgitation with crackles, fatigue, and atrial fibrillation. These patients can slip into pulmonary edema quickly. Monitor closely. 49. A patient with a prosthetic valve and fever. That's endocarditis until proven otherwise. Get blood cultures immediately before antibiotics. 50. Anyone with a valve replacement requires prophylactic antibiotics before dental procedures. This prevents infective endocarditis. Peripheral vascular 51. A limb that is cold, pale, and pulseless. That's an acute arterial occlusion. This is a surgical emergency. Notify immediately. 52. Pain in the legs even at rest. That's critical limb ischemia. It means the tissues aren't getting blood flow. Call the provider right away. 53. An ankle brachial index less than 0.9. This confirms peripheral artery disease. Monitor for skin breakdown and non-healing wounds. 54. Swelling, pain, and warmth in the leg. That's a deep vein thrombosis. The nursing action is bed rest and anticoagulation. NCLEX Pearl, never massage that leg. 55. Sudden shortness of breath, chest pain, and a fast heart rate. That's a pulmonary embolism until proven otherwise. Give oxygen and notify the provider. This is life-threatening. 56. Varicose veins with an ulcer. This is chronic venous insufficiency. Compression therapy is the treatment, not surgery. 57. Raynaud's phenomenon, when fingers turn white or blue in cold or stress. Teach patients to avoid cold exposure and manage stress. 58. Claudication or leg pain with walking that goes away with rest. This is peripheral artery disease. Encourage walking until pain, rest, then repeat. It actually helps circulation. 59. A carotid brute with neurological deficits. This is a high risk for stroke. Notify the provider immediately. 60. After a carotid endarterectomy, new neck swelling with stridor. This is an airway emergency. Call the surgeon right away. Don't wait. Hypertension and crisis. 61. A blood pressure greater than 180/120 with symptoms? That is a hypertensive emergency. End organ damage is likely if you don't act quickly. The priority is IV antihypertensive medication and close monitoring. 62. Severe headache, blurred vision, and nosebleed. These are hallmark signs of a hypertensive crisis. This is dangerous because cerebral hemorrhage or stroke can follow. Monitor vital signs closely, prepare for IV medications, and notify the provider immediately. 63. Sudden neurological deficits in a patient with hypertension. Always assume stroke until proven otherwise. Activate the stroke protocol. Time is brain. 64. Orthostatic hypotension in an older adult. This is a fall risk. Assist them when standing and reinforce slow position changes. NCLEX Pearl, safety before mobility. 65. Pheochromocytoma, severe hypertension, sweating, and palpitations caused by an adrenal tumor. Never palpate the abdomen because it can trigger a hypertensive crisis. Notify the provider right away. 66. Pregnancy with hypertension and proteinuria, that is preeclampsia. These patients are at risk for seizures, so monitor closely and anticipate magnesium sulfate therapy. 67. Severe hypertension in the postpartum period. This is a red flag for stroke or seizure. Notify the provider immediately. This is not normal after delivery. 68. A patient on beta blockers develops bradycardia or wheezing. Hold the medication and notify the provider. Beta blockers can worsen asthma and COPD and slow the heart too much. 69. ACE inhibitors causing swelling of the lips, tongue, or face. This is angioedema, a true emergency. Stop the drug, maintain the airway, and call for help. 70. Nitroprusside infusion. This drug lowers blood pressure fast, but carries a risk of cyanide toxicity. Monitor thiocyanate levels and watch for confusion or metabolic acidosis. Pediatric cardiac 71. An infant who sweats during feeds and isn't gaining weight. That's a red flag for congenital heart failure. Feeding is their exercise, so if they can't tolerate it, the heart is struggling. 72. The knee-chest position relieves a cyanotic spell in tetralogy of Fallot. Teach parents this. It increases systemic vascular resistance and improves oxygenation. 73. Bounding pulses with a machinery-like murmur. That describes a patent ductus arteriosus. NCLEX nugget. Remember the machinery sound. 74. Weak femoral pulses compared to upper extremities. This points to coarctation of the aorta. Always check pulses in both arms and legs in infants. 75. Cyanosis that is not relieved by oxygen. That suggests a congenital heart defect. NCLEX loves to ask this. Oxygen doesn't fix a structural problem. 76. Clubbing of the fingers. This is caused by chronic hypoxemia and is common in children with cyanotic heart disease. 77. A child with tetralogy of Fallot who squats to breathe better. Squatting increases venous return and relieves cyanosis. This compensatory mechanism is classic for TOF. 78. Rheumatic fever with chorea, a new murmur, and a recent sore throat. Treat with penicillin to eradicate strep and prevent valve damage. 79. Kawasaki disease. Look for strawberry tongue, prolonged fever, and conjunctivitis. Treat with IV immunoglobulin and aspirin to prevent coronary aneurysms. 80. A cyanotic infant after cardiac surgery. Always suspect shunt occlusion. This is an emergency. Notify the surgeon immediately. Emergencies and shock 81. Cardiogenic shock. Look for hypotension with pulmonary edema. Oxygen, IV medications, and vasopressors are needed. These patients are critically ill. 82. Hypovolemic shock. Signs are tachycardia, hypotension, and cool, clammy skin. The fix is rapid IV fluid replacement. NCLEX Pearl, volume before pressors. 83. Distributive shock such as sepsis or anaphylaxis. These patients often have warm skin and low blood pressure. Treatment includes fluids, antibiotics for sepsis, or epinephrine for anaphylaxis. 84. Beck's triad, muffled heart sounds, jugular distension, and hypotension. That equals cardiac tamponade. This is an emergency that requires pericardiocentesis. 85. Asystole. This is a flatline. Start CPR, give epinephrine, but do not shock. Asystole is non-shockable. 86. Pulseless electrical activity, or PEA. The monitor shows a rhythm, but there's no pulse. Start CPR and search for the H's and T's. Hypovolemia, hypoxia, tamponade, tension pneumothorax, toxins, and so on. 87. STEMI in the emergency department. The standard of care is PCI within 90 minutes. Prepare the patient for the cath lab immediately. 88. A patient who collapses after dialysis with chest pain. Suspect a dangerous arrhythmia. Put them on ECG monitoring and be ready to intervene. 89. A patient in shock with a widened mediastinum on chest x-ray. That means aortic rupture. This is surgical. Call immediately. 90. Syncope after urination in an elderly male. This is a vasovagal episode. Place the patient flat, monitor vital signs, and provide reassurance. Medications and monitoring. 91. Digoxin. Hold the medication if the heart rate is below 60 in adults or below 90 in infants. Digoxin slows conduction, and bradycardia is a warning sign of toxicity. 92. Warfarin. Always monitor INR with a therapeutic range of 2 to 3. Teach patients to keep leafy green intake consistent, not eliminate it entirely. 93. Monitor APTT aiming for 60 to 80 seconds. Remember, heparin works fast and has protamine sulfate as an antidote. 94. Enoxaparin, or low molecular weight heparin. It doesn't need routine lab monitoring, but you must watch platelets carefully because of the risk of heparin-induced thrombocytopenia. 95. Thrombolytics such as alteplase. Contraindicated if the patient has active bleeding or recent surgery. NCLEX Pearl. Safety checks come before giving clot-busting drugs. 96. Amiodarone. Powerful antiarrhythmic, but watch for pulmonary toxicity. A new cough or shortness of breath should be taken seriously. 97. Statins. Monitor for muscle pain, which may signal rhabdomyolysis. Also, check liver function regularly. 98. Nitrates. Headaches are expected and benign, but hypotension is the danger. Teach patients to sit before taking nitro. 99. Beta blockers. They can mask the signs of hypoglycemia in diabetics. Always monitor blood glucose carefully in these patients. 100. Calcium channel blockers. Common side effects include peripheral edema and constipation. Teach patients to manage these proactively and monitor for worsening edema.